The flowable composite resin mock-up is an excellent tool for communicating interdisciplinary information to other members of the restorative team, while also increasing a patient's understanding and education of the planned clinical procedure. These composite prototypes allow the patient and the restorative team to establish parameters for size, shape, function, lip profile, incisal edge position, and gingival orientation, while eliminating confusion and misunderstanding. This reversible and prepless technique can be used by the interdisciplinary team as a diagnostic guide for establishing and developing the final restorative and aesthetic parameters. In some cases, these transitional restorations can be worn for months or even years by patients during interdisciplinary treatment. This process can be performed intraorally without the need for anesthesia. A clear vinyl polysiloxane impression material can be used to replicate the diagnostic wax-up. The matrix can be placed intraorally and used as a transfer vehicle for the flowable composite to be injected and cured. After adjustment and polishing procedures are completed, the transitional restorations can continue to be modified to satisfy the functional and aesthetic needs of the patient and the interdisciplinary team. And now I would like to share with you this technique utilizing a new next-generation flowable composite, Genial Universal Flow. The following presentation demonstrates the restorative management of two size discrepancies for the orthodontic patient utilizing this technique. An 11-year-old patient presents with a two-size discrepancy in the maxillary anterior segment. During orthodontic and restorative evaluation, it was discussed with the patient the importance of improved oral hygiene and the significance of achieving specific space requirements so the orthodontist could position the teeth in the most optimal restorative position. It is important that the appropriate and anticipated result be decided prior to the placement of the orthodontic appliances. This enables the orthodontist to position the teeth in a way that will facilitate the desired restorative treatment with a minimal preparation requirement. After review with the patient and orthodontist, a diagnostic wax-up is designed to modify the size and shape of the maxillary laterals. This wax-up allows the team to evaluate form and function, and if this wax-up is precise, it can be translated using this indirect direct flowable composite resin technique for an immediate visualization by the patient and the restorative team. A diagnostic wax-up is created to change the size and the shape of the maxillary laterals. A non-perforated clear plastic tray is sized to the diagnostic model. A uniform thickness of the impression material in the tray provides dimensional accuracy and stability. I place the diagnostic model into a beaker of water for 5 minutes prior to making the impression, and soaking the stone model facilitates its removal from the impression. A transparent polyvinyl siloxane material is injected into the maxillary impression tray. It is important to maintain the mixing tip of the syringe in the material to prevent air trapping and potential voids. Also, it's important to use non-latex gloves because the latex can change the curing behavior of the material. Immediately position the tray and material over the diagnostic wax-up model and use a firm and even pressure to seat until the gingival contours of the diagnostic wax-ups are completely encompassed by the material, and leave undisturbed for 3 minutes until the material is set. Notice how easily the tray removes from the model. This was achieved by soaking the model in water. The silicone matrix is easily removed from the non-perforated tray. If there is any excess material beyond the periphery of the tray, trim the material with a scalpel blade and re-inspect on the model. Next, I create small openings on the incisal facial edge of the lateral incisors with an 8-fluted needle-shaped finishing burr and an ET9 by Brasseler. It is important to clean the internal surface of the impression and the orifices with an applicator tip to prevent silicone debris contamination of the composite material. Also, the orifice should be inspected with a small tipped instrument to ensure a clear passage of the composite material, and remember to enlarge the orifice to the size of the syringe tip. I use 2 different tip sizes to inject the flowable material into the matrix. I use the genial syringe tip, which has an ergonomic design and facilitates placement of the material. And I use the AccuDose needle tube by Centrix. When using the AccuDose needle tube, inject the flowable material into the tube immediately prior to the restorative procedure. The PhotoBlock orange tinted tubes prevent light activation of the material and extends the life of the light activated materials. Before beginning the restorative procedure, the silicone tray is tried in and inspected for proper adaptation and a complete seat. It is important to rehearse the path of insertion of the syringe tip, and this can be accomplished using a periodontal probe. Notice the opening is placed at the incisal facial edge in the middle of each lateral incisor. After radiographic evaluation, a shade comparison and determination is performed prior to the restorative procedure. The caries is removed with a number 2 high-speed round burr, which produces rounded line angles. The outline form should be as conservative as possible without removing healthy tooth structure unless dictated by caries. A caries assessment is performed using an argon laser source, the Diagonodent by Cavo, and all internal line angles were rounded using the round burr at slow speed, and the cavity walls are made smooth to allow a better resin adaptation. A final visual and tactile inspection of the cavity preparation is performed with an 1112 Explorer by Ufridi. A final rehearsal to ensure a precise placement of the silicone matrix and the correct path of insertion of the syringe tip prior to the restorative procedure. Before adhesive surface preparation, each tooth is separated by applying a dead metal matrix, Teflon tape, or using the proximal adaptation technique with a small amount of glycerin on the adjacent teeth. The tooth is etched for 30 seconds with a 37.5% phosphoric acid semi-gel, gel etchant by Kerr, and agitated with an applicator tip for 10 seconds. Rinsed for 5 seconds and air dried using an ADEC warm air tooth dryer. And an adhesive was applied with an applicator tip and allowed to dwell for 10 seconds. Notice I also use a number 1 sable brush to eliminate any excess resin and air thin to ensure a uniform distribution of the adhesive and light cure for 10 seconds. After any excess resin is removed at the gingival interface, the clear silicone matrix is precisely placed over the maxillary arch and inspected for a complete seat and seal. An A1 shaded flowable composite resin, Genial Universal Flow, is injected through a small opening above the right lateral incisor. It is important to maintain a constant finger pressure on the buccal and lingual ends of the matrix. This ensures a tight seal of the silicone to the gingival interface of the tooth and an optimal adaptation of the material to the tooth surface. And the composite resin is light cured through the clear resin matrix for 40 seconds from the facial and 40 seconds on the occlusal lingual. The clear silicone matrix is removed. Notice the optimal biointegration of the flowable material with the tooth structure. And the excess polymerized composite resin is removed with a scalpel blade, a number 12 BD Bard Parker. It is important to prevent tissue laceration, and if necessary, an 8A instrument or a Zerka can be used to gently reflect the gingiva. The same procedure is accomplished on the maxillary left lateral incisor. The caries is removed with a number 2 high-speed round burr, which produces rounded line angles. This allows for a better resin adaptation since all internal line angles are rounded and the cavity walls are made smooth. After the adhesive procedure is completed, the clear silicone matrix is again placed over the maxillary arch and inspected for proper adaptation, seal, and for a proper path of insertion for the flowable material. An A1 shaded flowable Genial Universal Flow is applied with a syringe tip. Notice the controlled fluidity that comes from the thixotrophic property of this material. Thixotrophy is a structural breakdown of a material so it flows through the syringe tip when the material is stressed. And then the hydrogen bonding restructures and it becomes more viscous. Also, by maintaining a constant finger pressure on the buccal and lingual ends of the matrix, an optimal adaptation of the material to the tooth surface can be accomplished. The excess is expressed with this pressure and the residual material is removed using an M1 ball-tipped instrument by American Eagle. Continue to apply firm pressure and light cure from the incisal and facial aspect for 40 seconds. The clear polyvinyl siloxane material can be used as a matrix to cure composite resin because these materials have no opaque fillers. Although no studies report a decrease in polymerization, it is recommended to use a high-intensity curing light and to post-cure without the matrix in place. The silicone matrix is gently removed, and notice the composite sprue is removed with the tray. And the excess polymerized composite resin is removed with a scalpel blade, a number 12 BD barred Parker, and an interproximal scaler, a S2O4S by Ufridi. The composite sprue is removed and the incisal edges of the laterals are contoured with a 30-fluted pyramidal-shaped finishing burr, an H274 by Brasseler. The shape of this instrument facilitates finishing because it follows the anatomical contours of the facial and lingual of the incisors. The gingiva is reflected with an 8A instrument to prevent tissue laceration while developing the emergence profile. A short tapered diamond finishing burr, a DET3 by Brasseler, is used to finish the tooth restorative interface and maintain the natural anatomic contour of the tooth. It is important to use a dry protocol to visualize the tooth structure and the gingival margin area. An ideal contour and surface finish maintains the biological balance at the gingival interface. Notice the optimal emergence profile that was developed in the initial wax-up and the marginal integrity at the interface. The gingival and facial region is smoothed and polished with a high-shine silicone hollow cup using the high-luster polishing system by Kerhave. Polishing of the facial surfaces is accomplished with a high-shine silicone point using the high-luster polishing system by Kerhave. A loose abrasive diamond composite polishing paste and a goat hair wheel are used at slow speed, approximately 4,000 to 6,000 RPMs, to impart a high surface luster. The composite surface gloss can be further enhanced by using a dry cotton buff with an intermittent staccato motion at slow speed, approximately 4,000 to 6,000 RPMs. On the incisal fracture of the maxillary right central, the same restorative shade and biomaterial is utilized. A scalloped chamfer preparation is placed several millimeters in depth around the entire cavity using a 30-micron tapered diamond burr, a DET3 by Brasseler. A 37.5% phosphoric acid semigel, gel etchant by Kerr, was placed on the preparation and several millimeters beyond the anticipated restorative margin for 15 seconds, rinse for 5 seconds, and air dried with an 8X warm air tooth dryer for 5 seconds. An adhesive is applied to the enamel and dentin surfaces with a number 1 sable brush and dried for 5 seconds using an 8X warm air tooth dryer and light cured for 10 seconds. An A1 shaded flowable genial universal flow is applied, sculpted, and smoothed to an ideal anatomical contour. Notice the stability of the material on the brush tip. This characteristic allows precise placement. And light cure the material for 40 seconds. The initial polish of the incisal and facial surfaces is accomplished with a high-shine silicone point using the high-luster polishing system. The definitive polish and surface reflectivity is accomplished with diamond polishing paste and a soft white goat hair brush. The final polishing surface gloss is achieved by using a dry cotton buff with an intermittent staccato motion. The occlusion is inspected with the patient in an upright position, in centric occlusion, and inspected for any prematurities. Prematurities can be equilibrated using the pyramidal-shaped finishing burr, an H274 by Brasseler. This shape conforms to the appropriate curvature of the tooth surface and the restoration. Next, the patient performs protrusive and lateral excursions, and the transitional restorations are inspected for prematurities. After the equilibration is completed, the lingual surfaces are polished with a silicone point at low RPMs. The completed polished composite restorations. Notice the harmonious integration of this nanohybrid flowable composite resin with the surrounding natural dentition. Management of tooth size discrepancies in the pre-orthodontic treatment planning stages can be accomplished using this simplified technique with an improved next generation flowable composite resin, Genio Universal Flow. And this simplifies and improves the understanding and management of this restorative dilemma for the patient and the interdisciplinary team.